We can get started. Hello, everyone. Thank you for joining the Division of Rheumatology Grand Rounds. A couple of reminders before we start the session. This session is currently being recorded and it will be uploaded on the website later. There will be a Q&A session at the end, so please add your questions to the Q&A feature and not in the chat box so that it's easier to moderate. And now I'll let Dr. Singh introduce our speaker for today.
Good morning, everybody. It's my utmost honor to introduce Dr. Askling today. Dr. Askling obtained his medical degree from Uppsala University in 1996, and since 2015, he has been the head of the Clinical Epidemiology Division at the Karolinska Institute. He leads the Chronic Inflammatory Disease Research Epidemiology Research Group at Karolinska, and his group consists of more than 25 active researchers, including professors, senior principal researchers, PhD students, and research assistants. And he has published more than 250 articles, including some of the most seminal papers evaluating the association between RA and lymphoma, as well as DMARDs and lymphoma, or DMARDs and cancer in general. So please join me in welcoming Dr. Askling, and let's take a deeper dive into his talk entitled RA, DMARDs, and Cancer. Thank you, Dr. Askling.
Thanks so much, Dr. Singh, for that kind introduction. Let's see if we can make this work. No. Here we go. So thank you. Here are my disclosures, in case you're interested. And just to set the scene for this talk, here's the map of the world. You are here, I guess, although with Zoom, you never know where people are. And it may be that many of you are still in bed with your pajama on. I'm at work, I should say, and I am here at the very, or not the very end of the other end of the globe, but quite a distance from where you are. And I'll come back to this geographical location because it is of some importance for some of the studies that I'm going to show you. And I have a ton of slides, probably all too many. We will walk through a number of results. I won't spend too much time on the actual methodology in each of the studies that we're going to discuss the results of, but and I've taken the liberty of quoting our own studies, perhaps more than I should, but there will be other studies as well. So the topic was rheumatic diseases, DMARDs, and cancer, or RA and DMARDs and cancer. This is such a broad topic, and if you think of it, it's almost impossible to cover in a talk during 3/4 of an hour, because there are many different types of cancers. And just as we don't look at RA and lupus and scleroderma as being one room condition, but being distinct conditions, and in fact, probably each harboring a number of subtypes. It's the same with cancers, and we need to recall that melanomas has its own distinct set of biologies, probably not just one biology. Same for lymphomas. Lung cancer is a distinct form of cancer, distinct from colorectal cancer, even if, as with the rheumatic diseases, there are a number of genetic and other factors that clearly overlap across conditions. But the point is, there are so many cancers that talking about the concept of cancer overall, which you will see that many of us have used in our studies, is good for power reasons. It's good for precision, but it's, from a biological point of view, a little bit of a leap of faith. The other factor that makes it so difficult to talk about general risks or what to do in clinical practice is the fact that there are so many other factors influencing cancers: age and sex, geography, ethnicity, other genetic factors, and the range of lifestyle factors that vary across patients, so that it's difficult to generalize. And thirdly, of course, as we all as clinical practicing rheumatologists know, one individual with, say, RA is unique in his or her particular phenotype or disease trajectory or treatment history or other factors related to that RA disease. So a comprehensive overview of how rheumatic diseases, DMARDs, and cancer, how they link together would mean the sort of the product of all these bullets, which is a very large product. So what I've taken the liberty of doing is to narrow the title a little bit. I've cherry-picked a little bit. And so the revised title is Facets of the Association between RA, DMARDs, and Cancer through vignettes. Because after all, clinical research serves two purposes, and one is to inform biology and sort of medical discoveries, and the other is to optimize clinical practice. So we need to ask questions that reflect the questions that we are asked by patients, or we're asking ourselves in clinical practice. So the structure of this talk will be through vignettes, and we head straight to the first one. And this is actually not a patient. This is a colleague of yours. This is Dr. Christensen. She's a female. She's 60 years of age. She's a rheumatologist at your clinic. You may not know her yet, but she's a rheumatologist at your clinic. And she has an unremarkable medical history. She admits having smoked a few years when she was younger, but she quotes distinguished American who said, "But I didn't inhale," in order to downplay a little bit this smoking history. And she turns to you in the coffee room and says, "I've never really thought about cancer. What is my lifetime risk, actually?" So the question here is, if you're a female and if you're 60 years of age, what's the likelihood that you have been diagnosed with cancer if you're an ordinary individual, assuming there are averages, despite the fact that I mentioned that we're all unique, and what's the lifetime risk of ending up with a cancer diagnosis? 2022. So let's turn to the data, or rather, let's first try to depict this graphically. I'll use this abbreviation of life from birth to death as to set the scene of each of these vignettes. So what she's asking is, anytime after birth but before death, what's the likelihood of ending up with a cancer? And let's then turn to the evidence out there. If you look at general populations, and the US being quite similar to this population, which happens to be the United Kingdom, UK, the lifetime risk nowadays is close to 1 in 2 of being diagnosed with a cancer. You could argue that 80, 90, probably 100% of all males die with a prostate cancer, but certainly not from a prostate cancer. But the lifetime risk is so high that it's, for many of us, more a question of when rather than whether. And also, by the age of 60, 5%, so 1 in 20 of us will have a history of cancer. And since patients with all sorts of rheumatic diseases are also human beings, it means that 1 in 20 of our patients will present with a history of cancer, which sort of sets the stage for the clinical need for good data on what happens with previous cancers if you treat the patient with all sorts of immunomodulatory drugs. A fair amount of these cancers, of all cancers that occur, are preventable in one way or other. 15% across the board, 80% of all lung cancers, but 15% of all cancers are attributable, statistically speaking, attributable to smoking. Obviously, this is statistics, not individual attribution. So in the individual case, we can never say or can't tell for sure, but statistically speaking, some 15% are attributable to smoking. But the point I'm trying to make here is that ending up with cancer is very common. Many of our patients will do that. Many of us will do that. Many will already have, and therefore have, a history of cancer, which we need to factor in. So moving from the first to the second vignette, now we turn from Ms. Christensen to Ms. Robinson. She's a female, she's 61 years of age. She's newly diagnosed with RA. She's one of these 1 in 20 with a history of cancer. She had a breast cancer 6 years ago. It was a hormone receptor positive cancer. It was curatively treated, as far as we know. She was put on anti-estrogen therapy for 5 years, according to clinical practice at the institution where she was treated. Now she turns to you as her new friend in rheumatology and says, "Doctor, does this RA has anything to do with my breast cancer, that terrible breast cancer drug that caused aches and pain? The anti-estrogen therapy, that is." So what do we know about this situation? I can't see any one of you now, but I assume that many of you have met a patient of this type or asking a question of this type. I have at least met a number of them, so I was interested in the answer to this question. And so have others. There are a few studies out there. But again, to iterate the question, we're asking about a history of cancer leading up to the diagnosis of RA, or at least whether it's more or less common. And for breast cancers, you immediately think of estrogen and all sorts of aspects of estrogen exposure, which isn't unheard of as potential risk factors for RA occurrence and its phenotype. So there's something in here. In particular, if you then totally block estrogen by anti-estrogen therapies of different kinds. So this is an Italian study from a few years ago. It in terms of design wasn't perhaps super, but they did look at the relative risk of ending up with RA instead of not ending up with RA in individuals who had been treated for their breast cancer with tamoxifen, the reference, or aromatase inhibitors. So this is an internal comparison between tamoxifen and aromatase inhibitors, and suggesting that aromatase inhibitors, the more powerful means of decreasing estrogen, was indeed associated with an increased risk of RA. There's another study on a similar topic, suggesting that yes, maybe anti-estrogen therapies do increase the risk of RA. And there was the second half on lupus that I cut away. So mounting evidence, someone would say, that yes, the risk of RA would increase if you've been treated with if you've had a history of breast cancer treated with anti-estrogen therapies. So what we did was to perform a case control study in which we compared individuals who had just been diagnosed with RA to general population compared to subjects who hadn't been diagnosed with RA. And then we went back to see how often do these RA people in relation to the general population have a history of breast cancer. So that's the small figure 1 here. And the figures are odds ratios, suggesting, all are just below 1, suggesting that people with RA, women with RA, are less likely, a little less likely to have had breast cancer than are women of the same age, same time, who do not have RA at that time point when the indexed individual developed RA. Now, considering that breast cancer is such a common cancer, the expected lifetime risk is sort of 1 in 10. In RA, it would be 1 in 12 instead. So lesson number 1 here, RA, a history of breast cancer is a little less common in individuals with RA than in the general population. And interestingly, this a little less common, so relative risk just below 1 rather than above 1, was same across seropositive, seronegative RA. It was same with respect to the stage of breast cancer. It was same for the age at breast cancer, and same across ages at RA diagnosis. It was pretty generally evenly distributed across all these subsets of individuals or characteristics. Then we went on to, within these individuals, study the anti-hormonal treatments that they had been subject to. And again, comparing women with a history of breast cancer, never treated with aromatase inhibitors or tamoxifen, adding tamoxifen or adding aromatase inhibitors wasn't associated with the kind of increase in risk that we saw in the previous studies that had made, again, as I mentioned, it's perhaps not the optimal comparisons. Maybe there was a little bit of a protective effect in women exposed to both, but it didn't reach statistical significance. So that was the Vignette number 2 on what happens on an aspect of cancer, clinically important aspect of cancer in individuals who've just become patients with RA. Now, let's look forward and look at Miss Lewis. She is a woman, 58 years of age. She was newly diagnosed with seropositive RA, and she's a teacher, so she's well read in many respects. Her medical history, again, is unremarkable, but she's turned to Google and all sorts of social media and read that RA increases the risk of cancer. And she asks you as her new doctor or new rheumatologist if that's really true. So here we're looking at RA and onwards and ask what's the likelihood compared to individuals without RA that the patient with RA ends up with any type of cancer. And there have been many studies looking into this. Here's a meta-analysis from quite some years ago, suggesting that overall there is a slight net increase, the hazard ratio of 1.05. So 5% higher risk of ending up with cancer if you have RA than if you don't, based on a fair amount of studies. Many of these studies, those with a blue dot, they come from the Nordic countries. And now that you've been so kind to introduce or invite me to give this talk, I'll be a little bit of a patriot and say a few words on how we study cancer risks and other aspects of risks in RA using the national registries and the generally permissive environment for large-scale epidemiological studies in the Nordic countries. So again, you are somewhere to the left and I am somewhere in the middle, this projection. And let's look at the neighboring countries, the Nordic countries next to Sweden, where I am. That's Norway, Finland, Sweden, Denmark, and Iceland. Together, we have a population as big or small as California, around 30 million individuals. In each of these countries, there's a large-scale national rheumatology register running, and in each of them, these registers have been running for quite some time. These registers are, many of them, or several of them at least, are clinically integrated. So we use them, I use them in my clinical practice, and so does most of my colleagues, or all of my colleagues. We use them to register clinical information on disease activity and treatment. And we also, the patients register their experiences of the RA disease or the spondyloarthropathies in the same register, so the PROMs and PREMs. Now, these registers are a fantastic source of clinical data. So these aren't claims data, these are clinical data in a setting where we have public health care systems, we have national registers on cancer, for instance, and we also have personal identity numbers so that we can link information from one data source to information in another data source, which means that from cradle to death, we're on the radar screen as individuals, and it's difficult to escape unless you emigrate to Seattle. Which means that we have a perfect setup for large-scale studies of the kind that I'm going to present a number of additional examples of here. So we use the clinical data in this rheumatology register in each of our countries. the patient and doctor generated clinical data. We link those data up to a series of national registers on hospitalizations, on drug use, on cancer incidence, on death, on vital status, on socioeconomy, on workability, and a series of other pertinent covariates. We further link up these individuals and their data to general population compared to subjects, so that for every individual with RA, we match 5 individuals from the general population, same sex, age, same domicile, same year of birth, but without RA. And we also link these general population subjects to the same registers as we have for the RA individuals. And through a little bit of intricate data management to these large-scale data sets, I'm going to show examples from one which we're currently working on that contains 8 million people. We can identify or define and identify treatment-specific cohorts, and you'll recognize most of these treatments, plus cohorts of individuals who are naive to, it says, I don't know whether you can see my pointer, but it says naive RA, it's bio-naive RA. So the RA individual who have not been subjected to treatment with any targeted immunomodulatory therapies, or these general population compared to subjects who don't even have RA. And I think those two latter cohorts are pretty important because they serve as external anchors. Where are we with respect to risks in the RA population? Are they much higher or much lower, or on par with that in the general population? And for each of these cohorts, we can then add on information on their medical history and also the future cancer risk, so that we can contrast these to each other. So this is essentially the underlying methodology in many of the studies that I will show you next. And getting back to the risk of cancer in RA, I think you all know that RA has an association, a very strong association with malignant lymphomas. And there was a paper from almost 20 years ago now, in turn, based on patient trajectories, RA patient trajectories from the decades before 2006. So basically, this is what happens with RA if you do not treat it with modern era anti-rheumatic drugs. So you can see that for individuals with high disease activity and high sustained disease activity, the lymphoma risk will become quite high, not just in relative, but also in absolute terms. I think what we've seen and learned over the last years is that with better treatment, this excess in risk has gone down, and gone down not to the extent that it's gone, but gone down to the extent that what used to be, when I did my first studies on RA lymphomas 20 years ago, the relative risk on an average level was, well, the average relative risk was around 2. Now I'd say it's closer to 1.5. So that's one effect of modern era treatments. And the question is, of course, among those treated, whether we introduce risks by the treatment or not, which was a specific question for TNF inhibitors, but we'll come back to those. And again, looking in the era where biologics or immunomodulatory drugs weren't around, what was the risk of melanomas in RA? You may know that melanomas is one of those cancer types that is immunogenic in a sense, or most immunogenic. Well, it wasn't increased. Now, what about other types of skin cancers, non-melanoma skin cancers? Well, if you look at the two major types, patients with RA before the era of biologics were at the increased risk of squamous cell skin cancers, and perhaps a little bit of an increased risk also for basal cell skin cancers. So this information is critical for our understanding of the effects of immunomodulatory drugs, and this just exemplifies why it is so important to be able to compare to the general population. So that was RA in general. Heading over to the fourth vignette, Mr. Marlborough. he asks a slightly different question. He is a male, he's 67 years of age, and he's newly diagnosed with seropositive RA. Again, an unremarkable medical history, but 25 pack years of smoking. And he turns to you and says, I know smoking is bad. Someone told me that RA may have something to do with inflammation in the lungs, although he doesn't really seem to believe that. But he makes the inference that maybe I am at a particularly elevated risk of lung cancer then, both with this lung inflammation kind of RA disease and with 25 pack years of smoking. So I guess the question here is whether we think that smoking explains it all in RA with respect to the increased lung cancer risk. So we just did a study that was out just a few months ago, looking into a number of RA cohorts, comparing them to the general population or to population compared to subjects. And here in the red square, you see the relative risk, the adjusted relative risk of lung cancer compared to the general population. So for the all RA, the three cohorts we studied combined, it was a 74% increase in the risk of lung cancer. That's basically where we knew from before it would be. And then we looked at, in the lower section of that red square, we looked at those who were smokers versus those who were never smokers in one of these RA cohorts and the general population subjects matched to these RA patients. And we found that, first of all, we found that more people have been smokers than have been non-smokers. But we also found that the ever smokers had a slightly higher risk than the average, of course, but the never smokers had a risk that was above 1, although the statistical precision wasn't perhaps optimal. But we went further with the same study populations, and this time we stratified on the presence of rheumatoid factor or ACPAs and tried to adjust for smoking. And here you see the red square on model C, which is the relative risk within the RA population now. So we have dumped the general population comparators, and here you can see that if you have RF and ACPA, so if you're double positive, or if you have one of them, your risk is 6-fold increased compared to if you don't have either of these serological markers. Even an adjustment for smoking didn't do so much here. You can ask yourself whether adjustment for smoking would do so much here, because smoking is a risk factor for getting RF and ACPA in the first place. But at least the 6-fold increased risk if you have RF or ACPA positive RA compared to double negative. And if we look at this in absolute risks, we can see the double positive versus the double negative curve. This is a Kaplan-Meier curve of the incidence of lung cancer, counting from RA onset. At 10 years after RA onset, 2% of the ACPA positive group have developed lung cancer. And I guess here's one of the differences in healthcare systems. I assume, or I wouldn't be surprised if you subject all patients to HRCT-based lung cancer screening. We don't, but this article was supposed to raise the question of whether we should, and if so, if we should do that in patients with seropositive disease who are also smokers, especially since lung cancer has such a devastating prognosis. So I assume that you're still awake, and let's move on to vignette number 5, Mr. Anderson. He's a male, he's 71 years of age, is seropositive and erosive RA since 1 year. He has now ended up insufficiently controlled with methotrexate plus 5 milligrams of prednisolone or prednisone, and you consider to add some sort of BOTS DMARD. But he turns to you and and again, I bet you've met these patients. I am extremely afraid of drug-related side effects. I'd rather not take any drug at all. I know what I have, RA, but I don't know what I may get from the drug. And I assume the drug is terribly much worse than the disease. And by the way, I have abstained from any COVID vaccination. And he thinks that we asks rather, which is a good question, whether these new drugs that interfere with my immune system won't that cause cancer? So the question he's asking, and we're asking ourselves, is if you start a BTS DMARD, will that increase your risk of cancer at any time after you have started your treatment? And here we have accumulating evidence. Consider that we've been asking ourselves this question for 20 years, or even more. And consider that we started off in a situation where we had way too many cases of malignant lymphomas in the trials and in the early case series. Consider that we started off in a context where FDA weren't really sure these drugs were safe enough. And that we now find ourselves in a situation where we have accumulated quite some evidence, but also quite some remaining unknowns. But for TNF inhibitors, for the group of TNF inhibitors, I think we can say that yes, we started off quite concerned, and we're now much less concerned. Although it's always difficult to completely rule out that there are individual cancer forms in individual contexts of risk factor combinations where adding a TNF inhibitor wouldn't be a good idea. I think we can safely say that for the vast majority of patients, or for the average patient, over the observation times that we have currently accrued, so let's say up to the first 10 years, which is what the so far longest studies have stretched, we haven't found any major signal that TNF inhibitors would increase the risk. And here's just a compilation of results from some of our studies, looking at TNF as the first ever DMARD and looking at TNF as the second BDMARD. And in neither case do we find any signal, any clear signal. Maybe a little bit for squamous cell cancer needs to be understood in more detail, but at least the overall risk isn't increased. So again, this is one of the same studies in the previous slide, just showing how TNFs compare to other BDMARDs, not TSDMARD, but BDMARDs with respect to the overall relative risk of any invasive cancer in individuals with RA who've started a biological treatment. In the left panel, you can see all the different BDMARDs compared, and the BDMARD naive group, that's this penultimate left dot in the left section, compared to the general population, the left red dot, and the same analysis when we compare all the BDMARDs to the bio-naive group, that's the right part, and now the bio-naive group is the red dot to the right. So here you can play around with statistics and say that the risk of TNF inhibitors and abatacept is statistically significantly higher than in the general population, but that's of course because also the BDMARD naive group, as we saw previously, may have a little bit of a risk increase. So same, this is a slightly blurred figure, I apologize, but same publication. Here's the same overall data, but split by time on active treatment. So if we look at the 5 different dots in the TNF section, you can see that they are all placed roughly next to each other horizontally. For rituximab, same thing, the dots are quite close to each other. For abatacept, however, there is a little bit of a lesser precision, but also a little bit of what seems like an upward trend. For tocilizumab, the smallest group, the precision was obviously the worst, but the signals dots were all below rather than above 1. So a little bit of uncertainty here with respect to abatacept. Again, same study, looking at individual cancer sites, and we were quite surprised to see that among the sites we studied, there was one site that came out consistently across all drugs, and that was urinary tract cancers. I do admit having seen quite a few patients with urinary tract cancer on DMARDs, but this I don't think was anything based on, it was certainly not an expected finding, so we need to dig into this in greater detail. It may be just confounding by smoking, as smoking is a risk factor for, in particular for bladder cancer, to a lesser extent renal cancer. But by and large, it doesn't seem as if there are any other sites that that signals. So moving from TNF inhibitors to the other drugs, I showed you the results from one of our studies on the other drugs, other DMARDs. Here's kind of meta-analysis for rituximab, and there's really little in the existing literature to suggest that rituximab would increase the risk of cancer, neither overall nor for specific cancer sites. And same for tocilizumab. Existing studies do not suggest a marked elevation in the risk. I should say that many of these studies are from an oncology perspective based on way too short follow-up times. But at least this is what we have. So that's what we have to base our decision-making on. And for abatacept, I said there was something in our data, which is the 1.28 dot here in the left figure. A few others have also found signals of a potential increase. Some haven't. But I would say that among the DMARDs on the market, abatacept is perhaps the exception, where for the others we cannot completely rule out an increased risk. For abatacept, it seems that we're on the way to identifying some sort of potential small-scale increase, which in particular patients may be of clinical relevance. So a little bit of a question mark for abatacept. And then obviously if we move to JAK inhibitors, there have been a number of meta-analyses based on individual trials. So these are way too short follow-up times for cancer studies, yet in some of these meta-analyses, not in all, but in some, increased point estimates, even if not statistically significant, have emerged. So this was 1.42, the 42% higher risk with JAK than JAK plus methotrexate and methotrexate alone, was interpreted by these authors as no increase in risk because of the wide confidence interval. You could take a more conservative approach and interpret it as a signal of an increased risk given the insufficient statistical precision. Same for non-melanoma skin cancers across these trials, 44% higher risk in the JAK arms than in the methotrexate monotherapy arms, but of course not statistically significant, and in timeframes that are really questionable. How long does it take to develop a non-melanoma skin cancer? Other meta-analyses have come to similar conclusions, I would say, a signal for all cancers, but less of a signal for the non-melanoma skin cancers. Again, all these meta-analyses are based on clinical trials, in this case across indications. So for the oral surveillance trial, which I guess most of you know very well, this signal from the clinical phase 2-3 trials were replicated so that tofacitinib ended up with a higher risk than the TNF inhibitors. But again, here we have no external comparison. So we don't know whether it's the TNF arm that had a low risk or the tofa arms that were unexpectedly high, or both. which I think is one of the inherent weaknesses of running large-scale phase 3-4 trials the way we do currently. It's just a waste of money. And here's the relative risk. So 40, actually quite close to the meta-analysis of the trial, the other trials of TOFA and baricitinib. If you look at the Kaplan-Meier curve or the failure curves, it seems that they start to diverge around 1.5 years. So that's where the TNF arm takes off from the TOFA arms. And our question is, of course, and this is from a brand new additional analysis of data from the oral surveillance trial published in ARD just last week. So the question we have to ask ourselves is it reasonable to think that treatment with tofacitinib for 18 months could lead to an increased risk of clinically diagnosed cancer? And maybe it is. I think one thing we shouldn't do is to take things for granted, because we often tend to be quite biased in how we think the biology is. We should instead look into this in detail and see if we can unravel a hitherto unknown biology here. But there are a number of fishy elements with the oral surveillance trial, I must say. So here's another figure from the very recent post hoc analysis of the oral surveillance trial, splitting the population according to baseline cardiovascular risk, in a sense. But here looking at the cancer outcomes, and I think what Pfizer would like to demonstrate here is that if you go for the low risk elements, those who are at the very bottom of this graph, the absolute risk is low, and the risk of therefore many of the clinical risks with tofacitinib, if they are true, would be less clinically relevant. I don't think it holds perfectly true for cancer. It may hold true for some of the cardiovascular risks, but to me, the TNF arm almost always comes out as the low risk arm across all these subgroups. And here is the same post hoc meta-analysis, now looking at concomitant methotrexate, and it doesn't seem that having or not having methotrexate did an awful lot to the relative risk of being on TOFA versus the TNF inhibitor. So those were the trial meta-analysis, the oral surveillance, and then there are so far two observational studies, both from the US, both based on claims data, looking into the risk of JAKis versus DMARDs, and none of which, this is one, and here's the other one, found any higher risk of cancer with JAKis than with DMARDs. We've looked into this, of course, and I shouldn't say anything about the results as they are not in the public domain yet, but let me say that they are compatible with one of these two alternatives, that there is an increased risk or that there's not an increased risk. So this led the FDA, certainly, but also the EMA, the European Medicines Agency, to suggest that these drugs should be used only if no suitable treatment alternatives are available. And then they encircle quite a broad group of patients, those at increased risk of cancer, for instance, and how should we interpret that in clinical practice? You can wonder. And we should also be reminded that regulatory bodies look upon these signals as a class effect across all indications, rather than for the 50+ with one cardiovascular risk factor patients with RA, as in the oral surveillance study. We should also remind ourselves that there are really very little data on cancer risks with biologics used for non-RA indications in rheumatology. So at least we know something with respect to JAK inhibitors. They're going to be very well studied if we keep using them, as opposed to these drugs, which are considerably less studied, even if for each of them you can think up a biological hypothesis why they would be associated with increased or decreased cancer risks of some sort. But let's move on to the sixth and last vignette before we wrap up. This is Mrs. Smith. She has seropositive RAs in 7 years. You need to, and she's not doing well, you need to beef up her treatment. You're considering adding a DMARD of some sort, but she had a colorectal cancer stage 2. She was operated on for 5 years ago, and she's been healthy since. And she's been worried because one of your colleagues is a friend of her, and apparently your colleague said something about, aren't these drugs laden with all sorts of cancer risks? And she's quite worried. Will a colorectal cancer stage 2 come back? So here we're asking whether having had a cancer and then starting a biological DMARD will increase the risk of cancer relapse. And before we look into this, I think we should remind ourselves of which factors are the key driving factors with respect to relapse. Well, the by far most important one is time since the index cancer. 50% of all relapses in cancers occur within the first 2 years of the end of treatment of the index cancer. I'm not saying that after that coast is clear, because obviously you've got 50% of the relapses left, but time since index cancer is really important. And the type of cancer is also important. So for a stage 2 colorectal cancer, what's the relapse risk? It's around, in a low risk patient, it's around 10%. And if 10% occurs, if 50% of 10% occurs within 2 years, it means that there's a 5% risk that it may recur later. So that's the kind of ballpark estimates that we need to equip ourselves with, so we know how to respond to questions such as those of Ms. Smith. Again, there are a number of studies looking into the risk of relapse. And so far, I think, making a long story short, they haven't used the same outcome definition. They have mixed up recurrent cancers with relapses, with new cancers of other types. Some have had methodological shortcomings and ended up with seemingly extremely protective effects, reasonably because we cherry pick patients in an era where you shouldn't put someone on a biologic if he or she has had a cancer, but you still do it. Then you probably had a good reason for doing it. And a good reason for doing it could be that you have reason to believe that the risk of relapse was low. And then the observed result will be an inverse association between using TNF inhibitors and the risk of cancer relapse. So we did a study, and we've done a number of studies on risk of relapse. And here is just the result of one, where we compare those who are biologics naive to those who had received a TNF inhibitor, and we've monitored their relapse risks from the time point of treatment start and onwards. And you can see, taking statistical imprecision into account, that the curves are more or less the same. And if you analyze the data, you'll see that yes, depending on, irrespective of which analytic approach we took, we ended up with relative risks very close to 1, suggesting that adding, in this case, a TNF inhibitor didn't really change the risk of relapse, taking an awful lot of tumor-specific factors into account in these analyses. So we've made our best effort to remove bias from cherry picking. There are a few other studies that have come to the same conclusion. Here's a Danish study looking into TNF versus not TNF in patients with different immunomodulatory or different chronic inflammatory conditions, mainly RA and IBD. Again, no clear increase in the risk of recurrent or new primary cancers. Here's a US study looking into patients with IBD, comparing methotrexate, thiopurines, and anti-TNF agents with respect to risk of breast cancer relapse in women with IBD or RA, suggesting again no increase in the risk with anti-TNFs, maybe a little bit with thiopurines, but not with methotrexate either. With respect to other drugs than TNF inhibitors, there's really little evidence out there. There's some studies on rituximab that again haven't found any increase in the risk of cancer relapse. And I guess this is what is reflected in your treatment guidelines, although the evidence base here at that time point when they were conceived were very low. I think we can now say that they're not very low, they're low. And they do suggest, in contrast to the European guidelines that don't exist, they do suggest that you would, for patients with a treated solid organ malignancy, you just continue as if that solid organ malignancy hadn't existed. I would take a somewhat more cautious approach and say that we have to inform our patients, we have to inform ourselves on the inherent risk of relapse for this particular patient's cancer, factoring in the type of cancer, the time since its diagnosis, factoring in the need for this individual to be on an immunomodulatory drug, and also factoring in the wishes and expectations of this patient. So I think it's very much an individual decision that should be not dismissed and just automatically subject to the same recommendations as in patients without this condition, as it says, but a little bit more of an elaborate decision making. And I think I'll stop there and open for questions.
Thank you so much, Dr. Askling. That was amazing, and what a career, like developing some of these seminal papers. So truly appreciate you distilling the literature for us. I do have questions. So let me start with Dr. Wenner's question. Does seropositivity versus seronegative RA in smokers alter risk of the type or histology of the lung cancer? How you mentioned about the risk with smoking versus non-smoking. He's asking, does it impact the type of lung cancer you get?
I think that's an excellent question. We haven't yet looked into that. We're planning a number of additional, I don't know anyone else who's done it. We're planning a number of more detailed analyses on the same data set that we just recently published on. And the histology of lung cancer is clearly one aspect that needs to be investigated, in particular when restricted to smokers.
Right.
Okay. So the answer is, I don't know, maybe in 1 year's time we'll know more. We'll
stay tuned. In terms of the next question, he's asking, same from Dr. Wenner, is the increased risk of bladder cancer associated with methotrexate, and explain the increased risk seen with biologics? Would be interesting to compare biologics, for example, in IBD, where they don't use much methotrexate versus RA patients.
Again, an excellent question. I don't think that the current evidence doesn't link methotrexate to bladder cancer as far as I can recall, although I haven't specifically investigated this, but I like the hypothesis. I'd like to talk more to this, Mark Brenner.
Yes, I think you will be.
I will. I like the hypothesis because it could potentially, and I like the proposed study design that maybe comparing individuals with IBD who would typically be on a thiopurine instead, and comparing those to methotrexate in RA could be a way forward.
Sounds great. And I'm sure there will be a lot more discussion when you two meet one-on-one. And moving along, we do have a few questions coming in now. So we have 5 minutes before 9. What about the issue of treating RA with DMARDs in patients with a new diagnosis of cancer?
Yeah, so the question is perhaps, do we need to discontinue? And I think we're at an interesting crossroads now, because we've been so, or at least I've been so used to removing almost as a gut reflex, removing all the anti-rheumatic drugs to make room for surgery, to make room for chemotherapy, which in the cancer patient would be much more important than to avoid progression of erosions or like, at least for that time point. Plus, chemotherapy does the trick much better than methotrexate. We all know that. So many patients don't need anti-rheumatic drugs for months once they go on chemotherapy.
Mm-hmm.
But that conventional wisdom is now challenged by the advent of immunotherapy against the cancer, which won't affect the RA disease. So I think this question is very pertinent. It's becoming a clear clinical conundrum. We've been a little bit saved by the bell by being able to remove immunomodulatory drugs against the RA disease. But now probably we may not be any longer, at least not to the same extent.
Mm-hmm.
There are no studies, I can tell for sure, there are no studies that have looked into continuing DMARD therapy in patients with cancer to the extent that we can safely say that it works. I think we all have the odd patient or patients where we have done exactly this for good reasons. But I must admit that in my evidence base, the evidence base is slim for doing so. So this must be a very much an individual-based decision. I wouldn't keep going with the TNF inhibitor. Put it this way: I would remove abatacept. I wouldn't continue abatacept.
Mm-hmm.
I would not continue a TNF inhibitor in a patient who has developed a melanoma.
Mm-hmm.
For other types of solid organ cancer, there's always often an element of surgery, which means that you would have to discontinue it anyhow. And to the extent there's radiation involved, you would remove the methotrexate. So there may still be oncology-related reasons to remove the DMARDs.
Mm-hmm. Thank you so much. Dr. Starkybaum is asking about methotrexate and risk of lymphoma in RA, how there were studies years ago about lymphomas that disappeared after stopping the methotrexate. Comment about that, please.
Yeah, so lymphomas, I mean, that's the cancer type in RA. And maybe I was a little too quick on the lymphoma story. Yes, in the early days, there were reports of lymphoma, EBV positive lymphomas in patients with RA and also IBD, which once you removed the methotrexate went into regression. The kind of post-transplant setting, pre-malignant lymphoproliferative conditions that have been well described there. I think, first of all, they do not make up the bulk of the lymphomas. The bulk of the lymphomas are EBV negative, diffuse large B cell lymphomas, and they do not go away once you remove the treatment. So I wouldn't if one of my patients with RA developed a lymphoma, I wouldn't discontinue the methotrexate and see what happened to the lymphoma. I would remove the methotrexate, well aware of the fact that the patient most likely would receive an R-CHOP chemotherapy, and you don't want to have methotrexate around them.
Right. Okay. There are a few other questions that unfortunately we are running out of time for, but I've made a note of them and I will be sure to get back to you Brianna and Marina, and I'm sorry, there's one more anonymous attendee, which I cannot tell who asked. So if you can please email me, I'll make sure to discuss with Dr. Askling and get back to you. But in the meantime, so thank you so much, Dr. Askling, for this fantastic talk, and look forward to more studies coming from your group. Thank you.
Thanks so much. And thanks for attending and listening.